So alcohol withdrawal syndrome is it's one of those things that, like I said, is not typically well understood or typically adequately well treated, even by experienced internists. The big problems that I see, there's really two. The first thing is there's a lot of confusion about definitions when it comes to things like delirium tremens, also known as alcohol withdrawal delirium, and alcohol withdrawal syndrome. Those are two separate entities, and differentiating between the two is very important. The second big problem I see is with regards to management and the overuse of symptom-directed therapy as opposed to what's called front-loading therapy. And I will explain what I mean by that. So when I do these kind of discussions, I like to start with definitions because understanding the definitions of these different entities is extremely important in actually not only knowing how to treat them, but just understanding their natural course and things like that. So alcohol withdrawal syndrome, what is it? It's a syndrome, meaning it's a constellation of signs and symptoms that can vary from patient to patient, both in terms of the actual symptoms they experience and the severity. That's the definition of what a syndrome is. So in alcohol withdrawal syndrome, you have a patient who typically has gone abstinent, stopped drinking, typically within a period of a day, usually within 8 to 12 hours, who is in alcohol withdrawal, and they experience things like tachycardia, diaphoresis, psychomotor agitation, tremulousness, anxiety, nausea, vomiting, perceptual abnormalities. In the case of alcohol withdrawal syndrome, that can include hallucinations, specifically insightful hallucinations. And I'll explain the difference between insightful and non-insightful hallucinations in just a second. But those are the signs and symptoms that comprise alcohol withdrawal syndrome, okay? Setting that aside, there's something called alcohol withdrawal delirium, which is also called delirium tremens or DTs, okay? Delirium tremens, okay, is a severe form of alcohol withdrawal. Typically begins 3 to 5 days after a patient has become abstinent from alcohol intake, okay? In contrast to withdrawal syndrome, which is very rapid. Oftentimes patients will go into withdrawal even while their blood alcohol levels are still relatively high, okay? In delirium tremens, there's usually several days that pass, their blood alcohol level is 0, and this is when they first start to experience symptoms, okay? The symptoms in DT are similar to withdrawal syndrome. You're going to have, the same kind of psychomotor agitation, tachycardia, high blood pressure, autonomic instability. However, in DT, the autonomic instability is quite profound. You have oftentimes very serious tachycardia with sometimes dysrhythmia, okay? The other thing about delirium tremens that differentiates it from alcohol withdrawal syndrome is the hallucinations that are experienced in delirium tremens are non-insightful hallucinations or delusional hallucinations. So what do I mean by that? Well, a person who's having insightful hallucinations is fully aware that what they're seeing, hearing, sensing is a product of their mind. Okay, they're grounded in reality. They will often tell you that they're seeing things, hearing things, whatever. Okay, but they're aware that these aren't real environmental stimuli. Okay, if you have, I was going to say delirium tremens, but really any form of delirium, you have what's called non-insightful hallucinations. Okay, and hold on, this dog is being very annoying. So, hopefully she can calm down. So, delirium tremens, and any form of delirium, you have delusional hallucinations, okay? You're not aware that what you're seeing isn't real. Oftentimes, patients are reacting to their hallucinations. They're, very unstable. So, I said all that to say, withdrawal delirium is characterized by delirium. Okay, profound confusion, profound disorientation. Patients can be, if you're talking about just regular delirium, you can have hypoactive delirium where, people get overly drowsy or, very tired. We see that very often in elderly patients admitted to the hospital with any kind of medical illness, and in patients typically in the intensive care unit. So that's hypoactive delirium. Delirium tremens is usually a very hyperactive form of delirium with delusional hallucinations. So those are key things to differentiate between a regular withdrawal syndrome. The importance of differentiating those two things is in withdrawal delirium, the mortality rate is extremely high. Okay? Some studies suggest it's close to 20%. These patients have a very high risk of dying, where even in severe forms of a withdrawal syndrome, mortality rate is not nearly as high, okay, with adequate treatment, obviously. Okay? I think I do want to emphasize that. So withdrawal syndrome, 8 to 12 hours of abstinence. Sometimes patients present, their blood alcohol levels are quite elevated still. Delirium tremens, you're looking at like 3 to 5 days after they stop drinking, typically. Okay, usually their blood alcohol level is 0. Okay, alcohol withdrawal syndrome, you may have hallucinations, but they're insightful hallucinations, so the patients know that what they're seeing and experiencing is not real. Delirium tremens, they have delusional hallucinations. They're interacting with the things that their mind is creating. They're very agitated, okay? They're illogical. They don't make any sense. That's another key difference. Withdrawal syndrome, you can have some autonomic instability. You can have some tachycardia. You can have your blood pressure elevated. You can even have degrees of hyperpyrexia. Okay, body heat dysregulation. In delirium tremens, the autonomic instability tends to be very severe. Okay, to the point where the autonomic instability becomes itself the emergency. The dysrhythmia is an emergency that needs treatment. Okay, things that don't differentiate a withdrawal syndrome from delirium tremens are, like I said, just the presence of hallucinations. It's the kind of hallucinations that matter. So just because you're hallucinating doesn't mean you have DTs, okay? Another thing is seizures, okay? You can have alcohol withdrawal seizures and still not have DTs, okay? So that is not, you could have seizures with DTs. Or without, you could have DT without seizures, okay? So seizures is not a good way to differentiate between the two conditions, okay? And then I'll just say this, Wernicke-Korsakoff syndrome, which is, basically a combination of Wernicke's encephalopathy, Korsakoff psychosis. Wernicke-Korsakoff syndrome is a separate entity altogether. It can occur in patients with an acute alcohol withdrawal syndrome or with DTs, but its presence or absence does not help you determine it. In fact, it's a totally separate entity unto itself. You can have Wernicke-Korsakoff syndrome and not be in any kind of acute alcohol withdrawal at all, because Wernicke-Korsakoff syndrome is caused by vitamin deficiency. Well, it's caused by chronic alcohol-induced vitamin deficiency, specifically thiamine deficiency. Okay, and patients with Wernicke-Korsakoff syndrome typically have dietary deficiencies, right? A lot of them are like homeless people. Well, I'll get into the exam and history and everything. I'll move into the history thing right now. When patients come in with a possible withdrawal syndrome, you ask them typically about their alcohol use history. If they have a long pattern of alcohol use and have recently become abstinent or ran out of money, they can't buy alcohol, whatever, you want to get a gauge for, number one, how much do they drink, how long have they been drinking that much, and when is the last time they consumed alcohol. Like, we need a specific answer on that. Was it yesterday morning at 8 a.m.? Was it 2 hours before you got to the emergency department? Are you like literally drinking in the exam room right now? Or was it 5 days ago and you've been sick with some kind of illness and haven't been able to get out of bed, and now 5 days after being a chronic alcoholic for several years, you've had a period of days, not simply hours, where you haven't been drinking. Those are key historical features that will suggest whether you're dealing with a withdrawal delirium, which is a very high mortality condition, or a withdrawal syndrome, which is a lower mortality condition, does not need as aggressive, type of treatment. It can need aggressive treatment, and withdrawal syndrome without DTs can be very severe and can require ICU treatment. So I want to be very clear about that. It's not simply that DT is just an extreme form. Well, I don't even know if I want to say that that's technically accurate, but I'm going to say it because it helps you understand. You shouldn't think of DT as just extreme alcohol withdrawal. Okay, it's a separate, in many ways, it's a separate entity with some of the same signs and symptoms that are typically a lot more severe, and that's, I guess, the component that overlaps them a little bit. But it also crucially includes the presence of delirium. Okay, so if there's no delirium, you don't have delirium tremens by definition. I mean, it's just like anything else in medicine. This is why understanding the definitions is very important. For example, you can't have someone in diabetic ketoacidosis if they don't have acidosis, right? So, if med students and residents, you take a step back and understand the definitions. That's the most important thing before you learn about the history elements that you need to collect, before you learn about the exam elements that you need to collect, obviously before you learn about management and treatment. You have to get your definitions correct. It's crucially important to get it correct. Okay, so back to the history. Every resident or med student who presents a patient with alcohol withdrawal, we need to know, number one, their alcohol use pattern, how long they've had that pattern, relatively speaking, and when did they last consume alcohol. Okay? Because that's important to risk stratify them and see, what we're dealing with. We also want to know their history of alcohol withdrawal. Chances are very good that by the time a patient comes into the hospital and you're getting ready to admit them or consider admitting them, they have a long history of hospital admissions. They may not, but oftentimes they do. You ask them, what has happened other times that you've experienced withdrawal? Did you have seizures? Did you require the hospital, or was this something that was managed in the outpatient setting? If you were hospitalized, were you in the intensive care unit? Were you intubated? Was it so severe that you had to be put on a mechanical ventilator? Alcohol withdrawal syndrome is similar to other problems in medicine in that previous exacerbation severity is a high predictor of future exacerbation severity. So, for example, taking another issue, asthma, okay? We've all dealt with patients with acute asthma exacerbations, okay? And they show up in the ER, they're a little short of breath, they're wheezing, whatever. It doesn't seem all that severe, but then you get to talking to them and they say, yeah, I've been in the hospital a dozen times for my asthma, and oh, by the way, yeah, 6 of those times I had to be intubated and in the ICU for a week. Okay, those are patients that are going to get admitted to the hospital. It doesn't matter how good they look after a few nebulizers in the ER. Those are patients that are almost always going to be admitted to the hospital. Okay? In a similar fashion, patients who have a history of needing ICU care and even just hospitalization in general, patients who've had a history of seizures, those are patients that are typically going to get a higher level of care, not good patients to manage in the outpatient setting. So those are historical elements. Their drinking history, particularly when their last drink was, their hospitalization history. How severe was their previous withdrawal episodes? I mean, obviously, we also want to know about other medications they take. Benzodiazepine withdrawal can mimic alcohol withdrawal. It's kind of rare for benzodiazepines to cause extremely severe ICU level requiring withdrawal that is mimicking alcohol withdrawal, but it is possible. Obviously, we need to know, are they taking opioids? Are they chronic drug users? Because we want to know about co-ingestants, right? Before we give people massive doses of benzodiazepines. Those are really the primary things that we need through history. The other thing is, when you're talking to the patient, are they I'll talk about this more in the exam thing, but is the patient a good historian? Are they confabulating? Okay, what is confabulation? That's like making stuff up. You ask someone, what were they doing earlier this morning? I was on tour with Taylor Swift and Travis Kelce in Argentina, okay? When really they were drunk and passed out on a park bench. They just make up like these odd lies. That can be a sign of Wernicke-Korsakoff syndrome, okay? But anyway, I'll talk more about that in the exam. So I went over the definitions and the history elements. But like I said, you're presenting a case, you need to have those historical elements for your attending, okay? In terms of the exam elements, you want to note their vital signs, like do they have profound tachycardia or autonomic instability? That's a sign of more severe withdrawal syndrome, potentially delirium tremens. The neurologic exam is very important. If you're dealing with a Wernicke-Korsakoff syndrome, the most common exam findings are things like nystagmus. Okay, it's commonly taught that you get ophthalmoplegia, but actually nystagmus is far more common. You get cerebellar signs, ataxia, particularly if these patients are ambulatory. You get a staggering gait, it's basically like as they walk, they swagger back and forth. It's called titubation. Okay, that can be a sign of a possible Wernicke-Korsakoff syndrome. Okay, it's not that they have a positive Romberg test, like some med students and residents get that confused. A Romberg test does not test cerebellar function. A Romberg test tests proprioception. So a positive Romberg test doesn't really tell us anything about whether or not they have Wernicke-Korsakoff. What we're looking for is things like an abnormal heel-to-toe walk, and like I said, staggering type of gait, what's called titubation. All right. And then other exam findings, like I had already said, do they have memory impairments, particularly short-term memory impairments? If they have no ability to recall things that you just told them, that's also a sign that you're potentially dealing with a Wernicke-Korsakoff syndrome, right? Confabulation, which I already explained, is another sign. Okay? I think that's all I want to say about definitions, history, and exam. Differential diagnosis would be kind of the next thing. Okay, I already mentioned benzodiazepine withdrawal, and mentioned that it's a rare mimic of alcohol withdrawal syndrome. One important thing to keep in the back of your mind, particularly with the patient population that you're typically dealing with alcohol withdrawal, things like homeless people, is obviously if you're homeless, you're at very high risk for various forms of meningoencephalitis. Okay, so that should also be on the differential diagnosis. Hepatic encephalopathy can be also just a mimic, although typically with hepatic encephalopathy, particularly with high grade, or what's called high West Haven grade encephalopathy, you get hypoactive delirium. You don't really usually get a agitated delirium. Seizures can be another mimic. Okay. Sometimes you can have patients that basically had their first epileptic seizure, but they also have alcohol use history, and so that can, I guess, confound you in some way. With regards to seizures, it's important to note that alcohol withdrawal seizures are typically, I don't want to say they're rare, but I would at least say they're not common. Okay, and with alcohol withdrawal seizures, they are usually like a singular episode, or a very brief, like close in time flurry of episodes. It's not typically something that reoccurs constantly over a period of days. I suppose it could, but it's typically singular episodes or short flurry of episodes. Rarely will it lead to something like generalized status epilepticus. Okay. I think that's all I want to say about the differential diagnosis. In terms of the management and treatment, obviously the cornerstone management of alcohol withdrawal and DT is benzodiazepines. And then the cornerstone treatment of Wernicke-Korsakoff syndrome is IV glucose and vitamin repletion and very high doses of thiamine. When it comes to withdrawal syndrome DTs, there are two general treatment approaches. Okay, I would say the most common one is what's called a symptom-directed approach. What is a symptom-directed approach? It means that the nurse typically has a comprehensive set of drug orders, and there's a certain dose of Valium, Ativan, whatever, that they give based on the severity of the patient's symptoms. The severity is typically determined by various scales. The most common one is something called the CWA scale. Okay, which CWA, I have to look it up exactly what it stands for. Clinical Institute for I don't know. I'm forgetting it right now. But the CWA scale is the one that is most commonly used. Okay, so if patients have a CWA score that is within a certain range, they get this dose of Ativan. If they have a CWA score that is very, very low, they may get no treatment at all. Okay. The problem with the symptom directed approach is similar, not quite the same, but most akin to like managing someone's blood sugar with sliding scale insulin. In other words, you wait until, in the case of withdrawal syndrome, you wait until the symptoms are severe enough to actually treat them, meaning you're not doing anything to prevent the symptoms from appearing in the first place. You're just playing catch up as the symptoms occur. In the example that I was comparing, blood sugar management, sliding scale insulin, you're waiting till the blood sugar gets high enough to before you actually treat them. Okay, so that's called playing like catch up, and it's not like a more aggressive preventative approach. The benefit of the theorized benefit of the symptom directed approach for alcohol withdrawal is it's thought you'll avoid over-sedation, right? Because you're only treating people based on what the current severity of their illness is. Okay. The other major approach is what's called the front-loading approach. This would be where you're giving someone doses of benzodiazepines essentially to achieve a desired level of sedation. This is the approach that I often use, okay, because I think it's safer, it has better outcomes, it results in fewer hospitalization days. Do I know that for a fact? I don't. That's just been my experience, so take that as just my opinion. And that approach, I think is just more aggressive and better for the patients. But in the front-loading approach, you are literally taking a patient, giving them, what I do is give them diazepam, okay, IV Valium, and you give it to them every few minutes until you tamper down their agitation, tamper down their, basically, whatever their symptoms are, their autonomic instability. And remember, benzodiazepines are a treatment for the autonomic instability associated with the withdrawal, right? So you have someone with extreme tachycardia, you give them benzos. You don't just jump to beta blockers or calcium channel blockers, whatever. You give them benzodiazepines. So with the front-loading approach, you're not necessarily using nurse-directed scales to give doses on a fixed kind of schedule. What you're doing is basically taking a patient, giving them however many doses of Valium that they need to achieve either an alert, calm state, that's preferable, but it's also acceptable to sedate them to the point where they're drowsy but easily arousable. Okay, so just talking to them, even if they're closing their eyes, you talk to them, they will wake up and be able to interact with you on a limited basis. You don't want to sedate them beyond that. Okay, so that's what I think is the most safe approach. Now, in terms of the benzodiazepines and the specific agents that you use, the preferred agent in patients without hepatic impairment is diazepam. It is not chlordiazepoxide. It's not Versed. It's not Ativan. It's diazepam. Why? Diazepam has a very rapid onset of action, and the IV form doesn't last as long as lorazepam, and because it doesn't have the secondary metabolites, okay, that lorazepam has, you have a lower risk of dose stacking and unpredictable effects on their mental status. Okay, the other thing is diazepam works very rapidly. Lorazepam not so much. Okay, so particularly in someone you need to get in more severe withdrawal and you want to get them under control really rapidly, you want to use IV Valium. Okay, and I would say in patients who are extremely severe where you don't have access to Valium, sometimes Valium in an IV form goes on shortage, midazolam can be a better alternative, okay? Because midazolam has the benefit of being rapidly acting. Now, if someone has extreme hepatic impairment, you may have really no choice but to use lorazepam, because diazepam is extensively... Can you stop whining? I know you want me to play with you, but I'm doing something right now. So I lost what I was saying. Oh yeah, so if you have significant hepatic impairment, you may be stuck using lorazepam. Okay, so if that's the case, just realize that the lorazepam does not work as rapidly. And if you're doing the strategy that I said, where you're front loading them and giving them doses every few minutes, you want to stretch that out. So with Valium, I typically will give them like 10 milligrams IV, wait 5 minutes. Usually I wait 10 minutes. Not, 5 minutes is sufficient, but 10 minutes makes the nurses more comfortable. So I typically wait 10 minutes, give them another dose, wait 10 minutes, give them another dose, wait 10 minutes, give them another dose, until I get them lightly sedated. That's my initial approach. If you're using lorazepam, you can't give it every 10 minutes. I mean, you're going to use like 2 to 4 milligrams every 20 minutes at least, something like that. Because again, you're at risk for overlapping doses, and basically what it comes down to is you're not sedating them as much of a predictable way as you would with the Valium. So I hope that makes sense. Oral benzodiazepines for withdrawal can be appropriate, but never, in my opinion, in patients who are hospitalized. And the reason is because if patients are hospitalized, that means, for me, that they have at least a moderate withdrawal syndrome, or are at risk for at least a moderate or more severe withdrawal syndrome. So by definition, any patient I admit to the hospital with a more severe or with alcohol withdrawal, by definition, will have more severe withdrawal. Therefore, I'm not going to rely on their oral absorption. Okay, and obviously the other thing is with IV access and with IV forms of Valium, more rapid onset, more predictable, etc. But oral benzos can be appropriate for the outpatient setting. Okay, the way that you do withdrawal treatment in the outpatient setting is you typically will give them, in the case of Valium, it's usually 10 to 20 milligrams orally every 6 hours for the first day or two, and then over a period of like 3 to 5 days, you'll taper that off to 0. Okay. Obviously, that assumes that they're the type of person who's going to be compliant with treatment, which, let's face it, a lot of these patients are not. And they're also hopefully not the type of patient that's going to go to the pharmacy, pick up 30 tablets of 10 milligram of Valium, take them all at once with a vodka chaser. That's obviously, if they're at high risk for doing that, those are patients you don't want to manage in the outpatient setting. Hey, come here. She's just crying constantly. Come here. Yeah, I know. We'll go for a walk here soon. Okay. So, I think that's what I wanted to say about just oral. So oral is typically, for me, only outpatient. Now, there is some data that you don't even have to use benzodiazepines in the case of mild withdrawal. You can use gabapentin. There are protocols you can find where you're giving someone regular doses of gabapentin, and gabapentin has been shown to have similar outcomes to oral benzos. But again, obviously, that would be an outpatient thing. Okay, so if for whatever reason you don't want to use benzodiazepines, gabapentin can be a alternative. Patients who are admitted to the hospital with more severe forms of withdrawal, who are benzodiazepine resistant. Let's say you spend an hour or two, you're giving them, frequent doses of Valium. They're still really not well controlled. Those patients may need to be put in the intensive care unit. And the reason that they're put in the intensive care unit is because oftentimes they'll need adjunct agents. They'll need very, very high doses of benzos, plus things like propofol, especially if they're going to be intubated, right? They'll need high doses of, sometimes barbiturates are added. Sometimes, we use things like Precedex or dexmedetomidine. Obviously not in patients with heart blocks or contraindications to Precedex, but Precedex can also be used, and typically we do not use that outside the intensive care unit, or at least a step-down unit setting, because it's an IV drip, so to speak. So I said all that to say, yeah, some cases where you're using really massive doses of benzos and not getting a good response, you may need adjunct agents. But I'd say more important than that for most patients is you need to give them adequate benzo doses. And what do I mean by adequate? Again, like I said, enough to achieve light sedation. This could mean that you're giving them hundreds of milligrams of Valium within a 24-hour period, sometimes over 1,000 milligrams. I mean, that can be necessary. And obviously the concern is, you give someone massive doses of benzos, is it going to cause respiratory depression? Usually benzodiazepines by themselves, and I'm saying usually, it's not 100% rule that you can just stick to. Usually by themselves, benzodiazepines won't cause respiratory depression. In very high doses, obviously they can cause profound sedation, but that's the reason why you use agents that are safely and rapidly titratable, like Valium, okay? You will run into fewer cases of oversedation if you're using IV Valium as opposed to other agents. And sometimes you can't use Valium because of drug shortages or because someone has serious liver impairment, which alcoholics commonly do, or I should say not uncommonly have severe enough alcohol impairment that Valium's maybe not a good idea. But Valium is the preferred agent. Okay, I hope I made that clear. If you're dealing with a Wernicke-Korsakoff syndrome, okay, you give them, this is actually a little bit more simple, you give them dextrose containing IV fluids, then you give them the vitamins, IV thiamine, 500 milligrams over 30 minutes, okay? And if it's a real Wernicke-Korsakoff syndrome, it's usually 500 milligrams over 30 minutes every 8 hours for the first 5 days, I'd say. Okay, it's not a rapidly just give them a dose of just give them some oral thiamine and send them home. No, this is, if it's real Wernicke-Korsakoff syndrome, it's high dose thiamine, dextrose, multivitamins over a period of days. Okay, I give everybody who's admitted to the hospital with alcohol withdrawal syndrome, I give them 500 of IV thiamine and dextrose just to begin with. I do that for everybody. Is that overkill? Probably, but thiamine's, a water-soluble vitamin. Giving someone 500 milligrams of thiamine is not going to harm them. It's not. There's a lot made about banana bags, multivitamins, stuff like that. I think those things are fine. I give those too. They're oftentimes part of the admission order set, so those can be given too safely. You do want to make sure you give the dextrose first, and you'll especially encounter on board exam questions, you give dextrose before you give the vitamins. The other thing is I give people magnesium typically. Number one, because a lot of chronic alcoholics have a magnesium deficiency, but magnesium is also a cofactor in thiamine metabolism. So for that reason, everybody who's admitted to the hospital gets high dose IV thiamine initially. I mean, I'm not going to give people with more milder withdrawal days and days of high dose thiamine, but just initially until I get a gauge of how severe it's going to be, yeah, I give them high dose thiamine and magnesium. So, and then replace their electrolytes, etc. The reason why I don't give lower doses of thiamine is there are some older studies that I've read that even 250 milligrams of thiamine is too low for people with true Wernicke-Korsakoff syndrome. So that's why I use 500. Okay. The American Society of Addiction Medicine, they released guidelines on the management of alcohol withdrawal syndrome that said basically any chronic alcoholic needs some IV thiamine, not oral, IV. Okay, that's just what they recommend. Another thing I want to just mention, since I made a big deal about the hallucinations, is there is a tendency or a propensity for some people to give antipsychotics to treat these delusional hallucinations, or even not delusional hallucinations, even people with insightful hallucinations. You do not want to give, you don't want to give antipsychotics, okay? You don't want to give them Haldol usually. And the reason is, there's two main reasons. The first reason is haloperidol in particular has been shown to lower the seizure threshold, okay? So that's the first reason you want to avoid it. Second reason you want to avoid it, a little bit more rare, but it happens. If you have a withdrawal-induced hyperpyrexia, antipsychotics can interfere with heat dissipation, okay? So those two main reasons are why I avoid it. Also, again, the benzodiazepines will typically be enough to treat the hallucinations. And the hallucinations themselves are, I was going to say directly treated by the benzodiazepines, but I don't really think that's maybe technically accurate. But the hallucination is part of the natural course of the withdrawal. And by treating them with high doses of benzos, typically those will resolve and not be an issue, okay? And the same goes, the benzos also treat the autonomic instability too. So before you start giving, this is obviously in the absence of dysrhythmia, right? Assuming you're just dealing with sinus tachycardia and very high blood pressure, the benzodiazepines should alleviate some of that, okay? Obviously, if someone has a concomitant, rapid atrial fibrillation and it is an actual atrial dysrhythmia and it's not sinus tachycardia, then okay, yeah, you maybe additional, like esmolol or something like that can, that you add that type of stuff. But in that case, you're treating the atrial fibrillation separately. But in the case of just autonomic instability, the benzos will take you very far. So I think that's about it on my kind of free-floating discussion of alcohol withdrawal syndrome. Like I said, it's a very common problem. The big things that I see that are done incorrectly is number one, there's not people don't understand the difference between delirium tremens and alcohol withdrawal syndrome. And it's important to understand the difference because true delirium tremens is obviously more rare than alcohol withdrawal syndrome and carries a much higher mortality rate and has a different time course of onset than just a regular withdrawal syndrome, okay? And the other thing is people being too afraid of benzodiazepines or inappropriately relying on CWA scales and symptom-directed therapy when you're dealing with more severe cases that are going to get out of control unless you take aggressive, active steps to appropriately sedate those patients. So I hope that all makes sense. I think that's all I want to say, and thank you for your time today.